The ROSiA study is phase 4 study in ovarian cancer, which was designed to assess mainly the safety of the combination of carboplatin, paclitaxel and bevacizumab in frontline. But the main rationale was to extend the use of bevacizumab behind the 15 months, which is the duration for the current label of the drug. So patients were treated for up to 24 months. These were 121 patients and they were enrolled in 35 countries around the world. The main side effects from the ROSiA study was hypertension and neutropenia. So altogether, I think the treatment was quite well tolerated. The important observation was, of course, the efficacy, which was the secondary endpoint, because the median progression-free survival observed in this study was 25.5 months, which is the longest ever reported with this treatment in ovarian cancer. Also, the median PFS was 18.3%, which is quite interesting. The results of this trial actually suggest that probably the prolongation of maintenance with bevacizumab may be beneficial to patients. Of course, this was not a randomized study, so we have to wait for the results of an already concluded trial run by the AGO group, and they randomized patients to receive 15 months versus 30 months of maintenance bevacizumab. So the results will be available probably in 2016 or 2017, and this will give us the definitive answer. The current analysis was actually a post hoc analysis trying to correlate the progression defined by RECIST criteria with the progression defined by the CA 1-5. This, of course, is very important because CT scans are expensive, are toxic and inconvenient for patients. The results of this study were quite intriguing, I would say, because they showed that there was not a good correlation according to the progression defined by CT scan or RECIST compared to the CA 1-5. 58% of patients did not have a correlation between the progression as defined by CT scan and the progression as defined by CA 1-5. And particularly of these, 26% had an increase in CA 1-5, but this did not reach the GCIG criteria for progression. There were 21% of patients who even had a decrease in CA 1-5, despite the fact that the CT scan showed a progression. Of course, the authors claimed that probably CA 1-5 should be abandoned, but I think this is too strong. So I think this data should be really taken with big caution. And we cannot come up to the conclusion that CA 1-5 should be completely abandoned. Fertility preserving surgery is offered to young patients with ovarian cancer, but of course we still do not know how much risky it is to leave the ovary and the uterus in a patient with ovarian cancer. The analysis of 545 patients who were treated around the world in several different institutions were collected by Dr. Philippe Maurice, and he focused specifically on the relevance of isolated recurrence in the ovary. Among the 545 patients, there were 12% of relapse. Of these, 24 were isolated in the ovary, and the other 39 were extra-ovarian. There was a correlation between the grade of the tumor and the percentage of relapse, but if we look at grade 3 tumor, the majority, more than 90% of relapse, actually occur outside the ovary, not in the ovary. Is this so true that if you look even at the data for patients after demolitive surgery, not conservative surgery, the relapse rate is pretty much the same. So my point is that yes, a patient with grade 3 tumor have a worse prognosis, and she should be informed about that. But this is not an absolute contraindication for fertility preserving surgery. She should know that the risk of relapse is about 23 to 30%, but probably this is not related to the fertility preserving surgery, but to the biology of the disease.